All right, so let's talk about transfusions because this is obviously one of the biggest things that we do for people with sickle cell disease. We're going to discuss, we use three main sort of types of transfusions. They're all transfusions of red blood cells, so don't get confused for the most part that we're transfusing anything else. We'll explain why we do what we do when we do it, and why we sometimes use exchange transfusions specifically. And then there's only a certain group that we try to keep on chronic monthly transfusions. So there's three main transfusion modalities that we use. The first is a simple transfusion, or my British friends call it a top-up. This is just your average, everyday, normal blood transfusion that you would give. You don't do anything but hang the blood. Each unit goes over about 1.5 to 2 hours, nothing too exciting. A manual exchange, however, is where we phlebotomize somebody, we pull blood off, usually, but not always, in about equivalent to the amount of blood we're going to give. And then we give them blood back as a simple transfusion, and we usually give that first unit faster, over an hour. And then we have automated red blood cell exchanges, or otherwise known as apheresis. It's like dialysis for the blood. This is where we hook somebody up to the machine to exchange their blood. It is a more rapid transfer of blood and removal of their own blood, and it's more efficient. In general, though, why don't we do transfusions for everybody? Because wouldn't that make sense? Well, we don't have enough blood in the world, so that's one reason. But the other reasons are that alloimmunization, or the formation of antibodies, is a big problem, as is iron overload. And we're seeing more and more iron overload as our patients get older. And then the rare complication of hyperhemolytic transfusion reactions, and the fact that our patients are at increased risk of transfusion-associated circulatory overload, i.e. fluid overload. So again, simple transfusions, it's just your top up. We don't remove any of the blood that's there. So this is important, right? Because that hemoglobin S is, our goal is to have less blood with S in it. And so if we're just adding blood, we're not taking any off. The manual exchange is where we remove blood by phlebotomy, and then we'll replace with healthy donor red cells. In the case in which we do it here, removal or phlebotomy precedes replacement. These are not done simultaneously, though you could do them simultaneously. And finally, automated exchange. This is the simultaneous removal and replacement of blood, and is importantly iron neutral and iron depleting in some cases. So why do we do these different procedures? Well, they all have benefits and risks. In terms of volemia, or volume-wise, only a red blood cell exchange is truly isovolemic. Same amount goes in that comes out, whereas simple and manual usually give more than they take. Blood viscosity, we see that the red blood cell exchange can better manage blood viscosity or thickness. Manual exchange does somewhat, but simple does not. So when we give more blood, there's more readily available red cells, so there's more blood viscosity or thickness. Iron overload, again, the only one that's truly neutral is the exchanges. Most people on simple will require chelation or iron management. And manual exchanges, if that's all they've ever done, will often not require chelation, but many will. And then you can see different procedure times that are involved. Apheresis is definitely the fastest. And so I would say that manual exchange is probably the longest because it takes a while to pull off the blood. So other key parameters or things we think about, volume, again, is one of them. A lot of our patients just don't tolerate volume well. And so when we're giving that simple transfusion, we're giving volume without taking it away. So often we use Lasix to follow that. The manual exchanges are simultaneous, or they're not simultaneous, but you give and take. And it's a little less efficient, but volume is usually relatively equal. And then our exchange transfusions actually can be hypovolemia inducing. Sometimes we take off more than we give, but in general are isovolemic and iron neutral. So this is one of the ways I like to think about it. When you think about giving blood or a simple transfusion, you're diluting what's there, right? So you're taking sickle hemoglobin and diluting the number of red cells that contain sickle blood with those that contain healthy hemoglobin A. And so you're just diluting it. You're not removing, you're not dumping out anything that's in the cup, but we know that can improve shortness of breath or dyspnea and fatigue, and can improve heart failure in certain situations. We definitely have that risk of this increase in blood viscosity. And importantly, we don't want to increase the hemoglobin to more than 10 to 11. Not only can this increase viscosity, but can actually cause complications of that viscosity in some cases. There's some limited data that suggested that when you did simple transfusion, you might actually increase stroke risk. It really had to do with patients that were getting too high a hemoglobin. And the reason is our patients' blood vessels aren't used to high hemoglobin. That's one reason. The other reason is when you give blood, you have two populations of cells. You have the red cells with sickle hemoglobin and the red cells with healthy hemoglobin. And those with sickle hemoglobin can pack together and be more viscous. So there was a study that showed that you could have a slight increase in risk of a hemorrhagic stroke, especially if you got that hemoglobin too high, because the blood vessel could burst. So we know that blood viscosity goes up if you increase hemoglobin, right? That makes sense. We also know that blood viscosity, the thicker the blood, that can actually limit blood flow and oxygen transport. That makes sense, right? If you have too many cars on the highway, it limits how many passengers can get out of those cars. And then, of course, as I just mentioned, the hemoglobin or the red cells that contain sickle hemoglobin can pack together more effectively than normal blood at the same hemoglobin. So somebody with sickle cell anemia who has a hemoglobin of 10, their blood is sort of thicker than normal blood of that same hemoglobin. Again, the way I think about this is those cars on a road, you can pack more sickle hemoglobin cars on that same street than you can normal cars because they're all damaged and easier to stick together. We also know that deoxygenated blood, so blood that doesn't have oxygen, is also more viscous. So again, if you take somebody with sickle cell anemia whose blood is thicker already and deoxygenate their blood, it increases the thickness, which slows down the blood flow. So that's just another way of thinking about things. The other thing that's important, even when we talk about exchanges, when you're giving blood out of a bag, the blood in the bag is deoxygenated, right? It hasn't gotten oxygen in a while. It's been in a bag. And so it has to get through the lungs and get reoxygenated before it's effective. So you'll often hear patients who get exchanges, especially, tell you they don't feel very good for a day after. And that's because all of that blood has to get more oxygen before it can function. When we talk about those exchange transfusions, though, you're dumping blood out and putting new blood in. So you're taking that Kool-Aid and making it look much more dilute. That's because you're immediately decreasing the amount of sickle hemoglobin and increasing the number of red cells with healthy hemoglobin. This is a simultaneous exchange of both of the blood at the same time as you get healthy blood. However, if you already have a vaso-occlusive crisis, it may not reverse because you may not get that new blood into the area very quickly where that occlusion occurred. Even if it does reverse, the injury caused by the occlusion may already be done. So patients may still complain of pain even if you exchange them. Other things that exchanges do, though, is helps decrease hemolysis faster. So in patients with a hyperhemolytic crisis, we might exchange them because it'll also decrease their bilirubin. It decreases the amount of free heme. We talked about how toxic all that free heme is. So when you exchange them, it takes that free heme out and is therefore safer and healthier for the kidneys. We're not going to worry about this for right now, but it's how we calculate what's done on an exchange. This is for us, everything that apheresis does for us. We don't have to do this, but it explains exactly how much hematocrit the goal is, and it's all based on what is their starting hematocrit and how much sickle do you want them to end up with. It also is important, however, because if people have a hemoglobin that's 6 or under, or about a hematocrit of 18 or under, They can't just be exchanged, because when you exchange somebody, remember, you're going to put some of their blood immediately into that machine. So if their hemoglobin's already 5.5 and a third of their blood goes in the apheresis machine, that's not going to work out very well. So usually those patients can just get a simple transfusion, or they have to get a simple transfusion and then an exchange. This is just more information on how we calculate exchanges. You'll sometimes hear our apheresis colleagues talk about FCR, and that's the fraction of cells remaining. So when we think about an exchange, we think about how much we're giving and how much we're not taking. And that not taking, or whatever we're leaving behind, is that FCR. And this is how we calculate it. When we compare exchange with simple transfusion, again, the simple transfusion is iron positive. You're giving blood. Every bag of blood has iron in it. Our bodies aren't so smart about iron, and we're going to talk about iron and iron overload separately. But what happens is the body takes that iron and just stashes it somewhere. It doesn't know what to do with it. It's not the way our body is supposed to receive iron, right? We're supposed to eat food with iron. And so it tends to stick it in the liver, the brain, or other organs where it doesn't belong. So one of the biggest differences between exchanges and simple transfusions is that our exchanges are iron neutral. We're not giving additional iron. It also prevents that volume overload that can cause a lot of problems. During the manual exchange, it is going to be almost an equal amount of blood taken and given, though usually we give a little more than we take. It's definitely less efficient, as you can ask any of our nurses who sit there and pull blood and pull blood and pull blood. It's annoying. And patients sometimes get frustrated because it takes a while. But it's still more effective than a simple transfusion for decreasing that sickle hemoglobin faster and giving back healthy blood. Iron overload, again, is a huge problem. This is actually an old study that tells us that about 10% of patients were found to have iron overload on autopsy. We actually would guess now it's closer to 25% because our patients are living longer. But we know that iron overload is associated with cirrhosis and liver failure. And we're seeing more and more myocardial fibrosis or cardiac fibrosis. This is obviously really bad. Heart failure sucks. And heart failure with iron overload is much harder to treat because getting that iron out of the heart is really difficult. In people with sickle cell, they tend to load their livers before their hearts, but there are some people, for reasons that we don't understand, who do load their hearts with iron very quickly and are really at risk for this iron overload associated cardiac failure. Regardless, it's also a silent killer, either whether it's in the liver or the heart. People can't feel that iron. So it means maybe they won't take their medicines because their medicine doesn't make them feel better. Not only that, but iron chelating medicines are hard to tolerate. And so then not only does the medicine not feel better, but sometimes it makes them feel worse. And so convincing people to take this can be hard. Alloimmunization is antibody formation. So interestingly, the red blood cells, when we think of blood type, like type A, B, or AB, is the only naturally occurring antigen-antibody relationship in our bodies. We're born with a specific blood type. It's a genetically inherited antigen. It's also a genetically inherent antibody. So if I have type A blood, which I do, my body, for reasons we don't totally understand, automatically makes anti-B blood, or anti-B antibodies, not blood. So even if I've never gotten a transfusion, I already have these anti-B antibodies in my blood. That's why it's so important to type and cross blood. In people with sickle cell, however, they're more likely to make antibodies than people without sickle cell disease. And especially in the United States, the majority of our blood donors are white, and the majority of our individuals living with sickle cell are of African and Black descent. So our blood tends not to match, and we have different antigens. So we don't just match at A, B, and O, but we also match at these other common antigens, C, E, and Kel. And that's because those are the antigens most likely to differ between the donor population and the people with sickle cell disease. When we think about Rh positivity, it sounds simple, like one antigen, right? You're Rh positive or negative. It's actually not very simple. The Rh antigen complex is actually made of multiple antigens. That's a real pain because you could be Rh positive, but only partially Rh positive. So we have to do a lot of specific typing to make sure our patients get the right blood. There was a concern when we started using exchanges because when we do an exchange, we sometimes expose people to 6 to 8 units of blood as opposed to just 1 to 2 units in a simple. So there was a lot of concern that we would cause more alloimmunization, but this study, as well as many others, have actually shown that we do not cause more alloimmunization. Interestingly, we cause less. So then we talk about, you'll hear us talk about chronic transfusions. There are some patients who get transfused every month on a schedule. Those are mostly people with neurovascular complications. So history of having had a stroke or having had MRIs or transcranial Dopplers, which are sickle stroke screens that show they're at very high risk of stroke. For those individuals, we want to keep their sickle percentage as close to or below 30% all the time. That really decreases their risk of having a stroke. We also sometimes use chronic transfusion therapy for people with recurrent acute chest. It can be very effective to decrease the frequency of their acute chest syndrome. And so you'll see that we do that as well. Chronic pain is a lot more complicated because everything to do with pain is more complicated. So we don't always use chronic transfusions for people with a lot of pain. As we talked about before, and we'll talk about more as time goes on, pain is a combination of how you feel, what your emotion is, and what your body's doing on any given day. So sometimes we can actually get people's blood level, their sickle blood, down to less than 15%, and they'll tell you they don't feel better, which doesn't make sense. You've taken all the sickle out, they can't have a crisis. So why don't they feel better? There's a lot of other reasons for that. However, there are some people who respond really well to chronic transfusions and recognize that they do better when they're chronically exchanged. So we will put some people on transfusions for chronic pain. But what's really important is to reevaluate them after 6 months, because if they're not getting better, we may be giving more risk than benefit, increased risk of alloimmunization and iron overload. And if it's not helping their pain, we probably shouldn't do that. And then there's a lot of discussion for specific organ complications, such as pulmonary hypertension or renal dysfunction, as to whether or not it is useful to do transfusions. We're actually studying that at present, and we don't know an answer yet. The biggest study, we love our acronyms, so you'll hear us talk about studies using their acronyms all the time. A study back in 1992 called Stroke Prevention Trial in Sickle Cell Anemia, or the STOP study. This was a study that showed if you took kids and used an ultrasound called a transcranial Doppler to look at their blood flow, you could identify who was at higher risk of stroke. And if you took those patients at high risk and put them on transfusions every month, you could decrease their stroke risk by more than 90%. So a fairly dramatic study. And we recognize that those are people who may need to be on transfusions forever. Because in the STOP 2 study, they said, can we, after we've done these transfusions for, let's say, a year, can we stop them? And they found that if they stopped the study, not only did it stop transfusions, not only did it increase the risk of stroke, but their stroke screen or their TCD turned positive again. So we found out that there was a majority of people that could not be switched from transfusion over to hydroxyurea or another drug. Then we had the silent infarct study. This is a more recent study that talked about the fact that some people don't have an overt stroke. They have a silent cerebral stroke. Could you improve these people if you put them on chronic transfusion? The study was positive. It showed you could significantly decrease either the increase in size of a previous silent infarct or the frequency of developing new ones. However, about 30 to 60% of people with sickle cell anemia will have silent infarcts. So we know it's not feasible to transfuse all those people. So figuring out who to transfuse with silent infarct is still sort of a question up for discussion. Again, acute chest syndrome, we don't have a randomized trial that's ever been done to compare putting people on chronic transfusion or what type of chronic transfusion to not transfusion to prevent acute chest. But we do believe that it's efficacious because lots of anecdotal data suggest that. And that when possible, we use exchanges, it keeps them iron neutral. And it's a most efficient way of keeping that sickle S% down lower. Again, looking at pain, we still aren't really sure whether transfusions decrease the number of pain episodes or the degree of chronic pain. There's a few studies that suggest that it does, but there are also some studies that suggest that it doesn't. So most important is when we have patients on transfusions for the purpose of pain or pain management, we want to make sure that we're making a difference because we're exposing them to risk. Also remembering that when someone's in the hospital for a regular old crisis, that's not a reason to transfuse them. We have no data that that helps. We have a lot of data you're going to increase iron overload. There's also no specific hemoglobin number where we say transfusion is absolutely required. It depends on both what their hemoglobin is and then their reticulocyte count, or how many new red blood cells they're making. And it depends on what their current issues are. Are they at risk of organ injury or having an organ-specific problem? We really want to avoid delayed transfusion reactions. And we're going to also talk more about these later. But when we have new patients, we'll often ask them, have you ever been told there was a delay in getting blood or that you have antibodies? Many of the patients can tell you, oh yeah, it takes 2 days to get my blood. That means we know we have to call any blood bank they've ever been in and find out what antibodies they made. Why is that? Because it turns out that patients, especially those with sickle cell, even if their antibodies are there, you can't always detect them. They're called amnestic antibodies. And so we could accidentally transfuse somebody with the wrong blood if we don't call previous blood banks. So we talked about transfusions, the different main 3 types of transfusions, why they're different. We talked about the benefit of exchanges and what population we put on chronic transfusions. Questions?
One quick question. Is it true that people experience more pain as they're about to get their next transfusion? Like I had a patient that was like, well, my pain tends to increase around the time when I'm due for another transfusion. So that was a lot of anticipation about it. But then we worked for 3 months and even she skipped her transfusion for other reasons and she never had a pain flare up. So that was a little confusing.
So yes, if you think about it, so blood that is in our bodies lives for 120 days, but blood that's from a bag lives for about 30 days, which is why we have to do it every month. Now, some people will hold on to that blood longer than others, but at the end of a month, they've decreased their transfused blood by a lot. So their sickle blood's higher. So that's why they feel worse. It doesn't mean they need a pain share. It means they have more of their chronic pain than they did before. So yes, they often have more pain as they're leading up to transfusions, but not always.
Okay, thank you.
Dr. Cantor, I had a quick question. Coming from the neonatal world, newborn screens were common where I've worked. However, they're not done in every part of the world, or every state, actually.
Yes, they are. So every state in the United States does newborn screening for sickle cell disease.
They do. Okay, perfect. I was wondering, okay, I've been reading, of course, trying to learn more about the disease itself and why it takes so long for it to be picked up in children. So I've been reading up about that. But there was a young man that I was reading about who was in his 20s, and he had gone through pain crisis and all this stuff, but was never diagnosed with sickle cell. He said that he was not tested. So I think he was maybe 30 years old, and they didn't find out that he had sickle cell until 2017. I was just wondering how a baby could slip through the cracks.
That's a much longer story, but it's not totally uncommon in that not everyone knows. And some people have pain and some people never have pain. So it's very hard to know, especially in people with SC or S beta plus disease who might not
has
become
SC.
anemic.
Yeah, he has SC.
Yeah, so we do definitely see that. But now in the United States, everybody who's about 25 or younger has
Mhm.
gotten a newborn screen.
Okay, good. I think he was about 30.
All right, other questions?
Good morning, Dr. Cantor and all. This is Tommy. So I was wondering, because it's important for us to have like release ROIs for everything when we are interacting with community partners and such. And so when you were talking about reaching out to the blood banks that the patient went to prior, I was wondering like, how does that happen?
So it's continuity of care. So you actually don't need a release of information for purposes of continuity of care.
I love to hear that because I've been arguing that with people here for a very long time. I'm like, that is part of HIPAA is that if it's continuity of care, we don't need a release of information, but you honor that and that makes work a whole lot easier. Thank you.
Not everything does, but it definitely does for
Mhm.
blood banks. For blood transfusion
Mhm.
purposes, the safety risk is too high and you're not
Mhm.
giving away, severe privacy issues. And so
Mhm.
now we've had places where we need medical records and they won't give them to us without a release of
Mhm.
information. But
Right,
blood bank
right.
to blood bank, it absolutely. And there's a lot of discussion about how we're going to make a universal blood registry, but it's a lot more complicated.
Thank you.
No problem. Other questions? Okay, happy Friday.
Happy Friday.